Welcome to the Rad Onc Smart Review Head and Neck Cancer series.
It is good to be back.
This is episode 32B, Hypopharynx Planning Workshop.
Mm-hmm.
Now, if you were with us for the last session, episode 32, you know we laid down the foundational laws. We established the rules of the road for the hypopharynx.
We really did. We covered the 4 absolute defaults, the nodal template, that crucial inferior extent ladder, and our priorities for organs at risk, or OARs.
And that was the theory. That was the classroom component, right?
Exactly. That was the textbook. Today, we're leaving the classroom. We are walking into the dosimetry room, sitting down at the contouring workstation, and picking up the mouse.
This is the practical application.
It is. The mission for today is simple, but absolutely vital. We need to build muscle memory.
Muscle memory is the key phrase here. It's one thing to know a rule intellectually. It's another thing entirely to have your hand automatically execute that rule when you are scrolling through a complex data set at, say, 7 p.m. on a Friday.
That's it. In high-stakes planning like the hypopharynx, you just don't want to be relitigating every single decision from scratch every single time. You want a robust framework that it fires automatically.
So that's the plan for today.
Yeah. So we are going to walk through 2 complete cases, slice by slice, decision by decision.
We want you to visualize the screen with us. We want you to feel the scroll wheel under your finger. And here is the challenge I have for you listening right now.
Okay.
Every time we approach one of those defaults we talked about, I want you to anticipate it. If you are a resident preparing for oral boards, or maybe you're an attending looking to refine your practice, try to beat us to the punch.
Say it in your head before we do.
Exactly. By the end of this workshop, those 4 defaults should be automatic neural pathways. They should be second nature.
Let's get into the work.
All right, let's pull up case A. We are starting with a definitive chemoradiation case. Let me paint the clinical picture for you.
Okay, let's hear it.
We have a 58-year-old man. He walks into the clinic with a history that unfortunately rings a very loud bell, a significant 40-pack-year smoking history.
Of course.
He presents with progressive dysphagia. He's been having trouble swallowing solids. Now it's progressing to soft foods. And he has noticed a mass in his left neck for about 3 months.
That 3-month delay is classic, and it's heartbreaking. The hypopharynx is a relatively silent area.
Yeah, so...
Well, unlike the glottis, where a tiny tumor causes hoarseness almost immediately, a piriform sinus tumor can grow quite large before it significantly obstructs swallowing or, throws a no that you can feel.
And that is exactly what we are dealing with here. We start with the flexible laryngoscopy, the scope goes down, and we see a mass in the left piriform sinus.
Okay.
It is involving the apex of the piriform, the very bottom of that pear-shaped trough. And here is a critical detail from the scope report. It is described as approaching the postcricoid mucosa.
Approaching. Okay, that is a loaded word. That's a huge red flag right there.
It gets worse. The arioepiglottic fold looks thickened. However, the true vocal cords are mobile, which is, I guess, a small mercy.
It is. That's something.
Biopsy comes back, as expected, squamous cell carcinoma.
So we have a piriform sinus primary. But the key phrase you just dropped is approaching the postcricoid. That should trigger a red flag in everyone's mind regarding the central compartment nodes. But let's not get ahead of ourselves. We need to see the imaging.
We have the full trifecta, CT neck with contrast, PET CT, and an MRI.
Perfect.
Let's start with the CT neck. It shows a 3-centimeter mass in that left piriform sinus. It's clearly replacing the air-filled space and demonstrates involvement of the paraglottic space.
Mm-hmm.
Now, for the neck, there is a necrotic 3.2-centimeter node in left level 2 and a 1.8-centimeter node in left level 3.
Oof. Necrosis in a level 2 node.
Yeah.
That is a hallmark of aggressive disease.
Mm-hmm.
When you see central necrosis, you're looking at a tumor that has outgrown its own blood supply. It is hypoxic, it is radioresistant, and it just demands respect.
We also have the PET CT. The primary is vividly FDG avid with an SUV max of 14. It confirms that nodal disease we saw on the CT. Fortunately, the scan is negative for distant metastases.
Okay.
And finally, we have the MRI. It confirms the paraglottic involvement, but here's the kicker, and I want everyone to pay attention to this radiology report phrasing. It notes submucosal inferior extension with an uncertain distal margin.
Uncertain distal margin. Okay, that is arguably the most terrifying phrase in a radiology report for a radiation oncologist dealing with the hypopharynx.
Explain that fear. Why does that phrase make your blood run cold?
Because the radiologist is telling you, I see the bulk of the tumor, but there is a tail of signal abnormality fading out inferiorly, and I cannot tell you where the cancer stops and the inflammation begins. And in the hypopharynx, we know from surgical pathology series that this cancer loves to crawl.
Crawl.
Yeah, it spreads submucosally underneath the lining where you can't see it with a scope and you can barely see it on imaging.
So staging-wise, we are looking at T3N2BM0.
Which is stage 4A.
Stage 4A. He has had his dental extraction, speech and swallow evil, and a PEG tube placed. He is on the table for simulation today. The consult question is simple. How do we contour this?
All right, let's visualize the workstation. We have the CT sim fused with the diagnostic CT, the PET, and that scary MRI.
All the tools are there.
All the tools. But before I even touch the contouring tools, there are 3 specific things I'm looking for. I call these my pre-contour analysis questions. You have to answer these before you draw a single line.
Okay, what is question number 1?
First, where does this tumor end inferiorly? The MRI explicitly said uncertain distal margin. We just discussed why that's a red flag. In the hypopharynx, I cannot trust the visible extent on the scan. Surgical series have shown us time and again that you can have 2 to 3 centimeters of submucosal spread that is completely invisible to the naked eye and to imaging.
Right.
So I have to plan for what I can't see.
This isn't like a tonsil cancer where the border is usually pretty distinct.
No, absolutely not. Not even close. This is a creeping malignancy.
And the second question you ask yourself.
How close is he to the postcricoid area? The endoscopy said approaching postcricoid mucosa. This has huge implications for our nodal volumes, specifically level 6, and potentially for covering the cervical esophagus.
How so?
Well, the postcricoid area is the gateway to the esophagus and the paratracheal chain. If the tumor is knocking on that door, we have to open our fields to cover those areas, period.
Makes sense. And the third question.
The nodes. Which nodes are involved and what escalations do they trigger? You mentioned he has N2B disease with a necrotic level 2 node. When I see a necrotic node, I need to make a mental note immediately regarding the gross tumor volume, or GTV.
Which brings us to the contouring itself. Let's start drawing. GTV delineation.
Correct. I am contouring on the CT, but I have the PET and MRI fusion visible.
You're toggling between them.
Constantly. Superiorly, I start at the aryepiglottic fold. It is thickened, so it is in the volume. I'm moving inferiorly, slice by slice. I am capturing the bulk of the piriform sinus mass. I see the paraglottic fat infiltration on the left. That low-density fat is replaced by gray tumor, so I am including that entire fat space.
And now we are reaching that tricky apex.
This is the critical zone. The tumor extends to the very bottom of the piriform sinus. On the MRI, that abnormal signal is pushing toward the postcricoid. For the GTV, I am including everything I can definitively call tumor, but, and this is crucial, I am already mentally preparing for a very generous clinical target volume, or CTV, expansion inferiorly.
So the GTV is just the starting point.
It's just the tip of the iceberg.
Now let's address the nodal GTV. You mentioned the necrosis rule.
Yes. Left level 2 contains that 3.2 centimeter necrotic node. Here is the rule. I contour the entire node. The capsule and the surrounding tissue are at the highest risk.
What's the common mistake here?
I see residents sometimes try to contour just the enhancing rim and leave the necrotic center out, or they contour the necrosis separately. Do not do that.
Why not?
The necrosis is tumor. It's just tumor that grew too fast for its vascular supply. The whole thing is GTV.
Got it. And the level 3 node?
That one is solid 1.8 centimeters. I contour the visible node. Simple enough.
Okay, GTV is done. Now we move to the CTV, and this is where the specific rules of the hypopharynx really come into play.
Stop right there. Before we expand, we hit checkpoint 1.
Okay, checkpoint 1, let's hear it.
Hypopharynx default.
Lymph nodes.
Correct. This is non-negotiable in hypopharynx cancer. In glottic larynx cancer, cancer of the vocal cords, the risk of retropharyngeal spread is very low unless the tumor goes supraglottic. But in the hypopharynx, there is a meaningful validated risk of retropharyngeal lymph node involvement.
So the drainage pathways are just different.
Completely different. They lead directly there.
So even though his visible nodes are lateral levels 2 and 3 and the RPLNs look clean on imaging, we are covering them.
Yes, 100%. We are treating the drainage, not just the disease we can see. The hypopharynx drains to the retropharyngeal nodes regardless of where the gross disease is sitting in the neck. So I'm contouring level 7A bilaterally.
Let's review the specific borders for level 7A in this context.
Sure. The superior border is at C1, specifically the bottom of the transverse process of C1.
Okay.
The inferior border is at the cranial edge of the hyoid bone.
And why stop at C1? I feel like for nasopharynx, we go all the way to skull base.
You do, but that's because for the hypopharynx and oropharynx, the lateral retropharyngeal nodes, the nodes of Rouvier, are the primary landing zone, and they sit right in that C1 to C2 region.
Ah, I see.
So unless there is gross disease climbing higher or this was a posterior pharyngeal wall primary tracking up, C1 is sufficient. Going to the skull base just adds toxicity to the constrictors without adding real oncologic benefit for a clean scan. Got it. So C1 to cranial hyoid, RPLN is done, both sides. Now let's talk CTV expansion.
All right, we build our tiers. First, CTV high, which will receive 70 gray.
70 gray.
This is our GTV primary plus a margin. Now, in most head and neck sites, we say 5 millimeters. But here is the hypopharynx specific modification. I am using closer to 10 millimeters, and I am being very generous in the craniocaudal direction. That is up and down.
Why the extra margin there, especially craniocaudally?
The Gregoire consensus guidelines specifically note that the hypopharynx may require larger craniocaudal expansion up to 1.5 centimeters for the CTV, specifically because of those submucosal spread patterns we mentioned.
That crawling tumor again.
That's the one. So I am expanding, checking that I have captured the paraglottic space, the aryepiglottic fold, and the medial piriform wall. For the nodes, it's GTV nodal plus 5 to 7 millimeters for the CTV high.
Okay. Now for CTV intermediate, we are targeting 63 gray here. This is a volume we don't always use in every head and neck site, but here it seems essential. It is essential. This volume captures structures at risk that aren't quite in the high dose volume. I am including the entire involved hypopharyngeal subsite.
The entire thing. So even though the tumor is in the left piriform,
both piriform sinuses get intermediate dose. Because the rich cross-drainage and just the proximity, I am also including adjacent laryngeal structures, the false chords, the arytenoids, and generous paraglottic coverage. We also include the preepiglottic fat and the prevertebral fascia in this intermediate dose.
You mentioned prevertebral fascia. Why is that so important to cover?
The hypopharynx sits directly on top of the prevertebral fascia. Unlike, say, the tonsil, which has the constrictor muscle as a bit of a buffer, the posterior wall of the hypopharynx is just millimeters away from the fascia. Invasion there changes the T-stage, it changes operability. We have to sterilize that interface.
This leads us to our next major decision point regarding the neck.
It does. Jet point 2.
What's default number 2?
Hypopharynx default number 2. Bilateral neck is on N.
Even with a left-sided tumor?
Even then, the hypopharynx has rich bilateral lymphatic drainage. The risk of occult, hidden nodal disease on the contralateral side is high.
How high?
High enough that treating only one side is not standard of care. There are very, very few exceptions to this rule. Maybe a tiny T1 on the lateral wall. But for a T3, never. My baseline is bilateral levels 2 through 4, plus that RPLN we discussed.
But this patient has specific escalations. He isn't just a generic case.
Right. And you have to account for that. He has N2B disease with bulky level 2 involvement. That bulky disease changes the flow dynamics in the neck.
It's like a traffic jam.
It's a perfect analogy. When the main highway level 2 is blocked by a big tumor, lip fluid diverts, it goes backward into the posterior triangle.
Which means
that triggers level 5.
Yeah.
I am treating level 5 bilaterally.
And the postcricoid issue? The scope report saying approaching postcricoid?
Because of the apex involvement approaching the postcricoid, that raises the question of level 6, the anterior compartment. I'm going to include it.
So just to recap the elective nodal default, bilateral 2 through 4 plus RPLN. Then we add levels 5 or 6 based on a specific spread.
Exactly. Now, we have to address the bottom of the field. This is where most failures happen. This is the big one.
Checkpoint 3.
Hypopharynx default number 3. Inferior extent. Assume it goes lower than you want.
This is the default that saves patients' lives.
It really is. I'm looking at my CTV on the axial view. I'm scrolling down. Here is the apex of the piriform sinus. This is where the GTV effectively ends on the imaging. But remember the MRI note.
Uncertain distal margin.
And remember the scope.
Approaching postcricoid.
And the surgical series data showing 2 to 3 centimeters of invisible spread.
Right.
My inferior CTV cutoff must account for what I cannot see. If I stop my field 2 centimeters below the visible tumor, I might be cutting right through microscopic disease. So I am at the apex, I am checking the postcricoid, I am adding at least 1.5 centimeters below the lowest visible tumor, at least. And because he is approaching the postcricoid, I am extending my intermediate dose volume, that 63 gray volume, to include the cervical esophagus.
Let's clarify that triggers list. What specifically makes you go lower than the inferior cricoid edge? Can you list them out?
Sure. 4 things.
Yeah.
1, apex involvement. 2, postcricoid extension. 3, cervical esophagus involvement. And 4, that's specific radiology report of an uncertain distal margin.
So if you see any of those.
Any one of those, I drop my field lower. I am chasing the disease into the upper mediastinum if I have to.
And what triggers adding level 6 in the upper mediastinum nodes?
A postcricoid primary, cervical esophagus extension, or paratracheal nodal involvement. In this case, he has apex approaching postcricoid. I am adding level 6.
Let's apply the nodal template slice by slice for this patient. I want to visualize the flow.
Let's walk through it. We start at the top, level 2, superior border at the caudal C, 1 lateral process, inferior border at the caudal hyoid, bilateral. His left level 2 has gross disease, so that entire level goes to the high dose volume 70 gray. The right level 2 is elective, so it gets 56 gray.
Okay, moving down to level 3.
Caudal hyoid to caudal cricoid, bilateral. Left level 3 has a node, so it's high dose. Right is elective.
Level 4.
Caudal cricoid to 2 centimeters above the nubrium, bilateral elective.
Now, level 5. This is the posterior triangle.
And I am adding this bilaterally specifically because of his E32B status with that bulky level 2 node.
So if you were, say, N0 or N1.
I might omit level 5 to spare him some shoulder stiffness, but bulky upper neck disease increases the risk of posterior triangle involvement. We just can't take the chance.
Okay, level 6.
The paratracheal nodes. His apex involvement approaching the postcricoid triggers this. For the inferior border, I am going to the thoracic inlet. If he had confirmed esophageal extension, I would go even lower, maybe to the aortic arch.
Wow. And we already covered level 7A, the RPLN. What about 7B, the retrostyloid nodes?
Good question. The retrostyloid nodes sit high up, behind the styloid process. Usually we don't treat them. But his bulky level 2 mass is pushing posteriorly. It makes me worry about retrograde flow into that high retrostyloid space.
So for him.
I am including level 7B on the left side base of skull to caudal C, 1 lateral process.
So the total map is bilateral 2 through 5, bilateral RPLN, left retrostyloid, and level 6. That is a massive, comprehensive field.
It has to be. You cannot be timid with the hypopharynx.
Let's talk about the dose painting. We are using a simultaneous integrated boost, or SIB technique, over 35 fractions.
Correct. We use 3 tiers.
Yeah.
Tier 1, 70 gray, that is 2 gray per fraction. This goes to CTV high, that is the GTV primary and nodal with our margins.
Okay.
Tier 2, 63 gray, 1.8 gray per fraction. This goes to CTV intermediate. This covers the entire involved hypopharyngeal subsite, adjacent laryngeal structures, the high-risk first echelon nodes, and the RPLN.
And tier 3.
56 gray, 1.6 gray per fraction to CTV low. This is for the elective nodal coverage, the contralateral neck, and level 6.
Why is that intermediate tier so critical in hypopharynx? In oropharynx, for example, we often just do 70 and 56.
Because of the submucosal spread. The areas that look clean on a scan might harbor microscopic disease that is denser than typical subclinical disease. They need more than the standard 56 gray elective dose.
But not quite the full 70.
Exactly. We can't blast everything to 70 gray without causing massive, unacceptable toxicity. So 63 gray hits that sweet spot. It covers the microscopic risk effectively without, burning the patient down.
No, optimization. We have to balance this aggressive coverage with the organs at risk. This is where the rubber meets the road.
Always the challenge. We start with the hard stops. Spinal cord maximum dose, 45 gray. The planning organ at risk volume, or PRV, is 50 gray. Brainstem maximum, 54 gray.
Non-negotiable.
These are inviolable. I check them before anything else because paralysis is not an acceptable side effect.
Then we have the priorities, the trade-offs. The big one everyone talks about is the constrictors.
Yes. The pharyngeal constrictors, superior and middle. The DARS trial was a landmark study. It demonstrated that keeping the mean constrictor dose below 50 grays, specifically the parts outside the CTV 70, significantly improves swallowing outcomes.
And that's a real tangible benefit for the patient.
Huge. We are talking about MDADI scores, a quality of life metric for swallowing of 78 versus 71 at 1 year. That is a meaningful difference. That is the difference between eating dinner with your family and relying on a feeding tube. So I will try to achieve this.
But there is a massive caveat here, isn't there?
A huge caveat. Look at our patient. His tumor is in the piriform sinus. It is physically pushing against the constrictor muscles. The constrictors are the target in many slices.
So what do? The trial says spare them, the cancer says treat them.
Here is the refrain, and I want you to say this with me. I will not spare constrictors at the expense of a marginal inferior CTV or a high-risk mucosal strip.
Say it again for the people in the back.
Geographic miss is worse than dysphagia. It's that simple. If I spare the constrictor and the cancer comes back, the patient dies. If I overdose the constrictor, the patient has dysphagia, but they are alive to manage it.
So DARS optimization is a secondary goal.
Exactly. His tumor sits right on his swallowing structures. Some constrictor dose is just, it's unavoidable. I optimize what I can, I accept what I must.
What about the larynx and thyroid?
For the larynx, we minimize the mean dose for voice function, but his CTV intermediate includes adjacent laryngeal structures like the false chords. The goal is function, not zero dose. For the thyroid, it is in the field. He will develop hypothyroidism.
So you don't even try to spare it?
I am not going to compromise medial nodal coverage to save the thyroid. I will just monitor his TSH every 6 to 12 months indefinitely and give him Synthroid. It's a manageable problem. A recurrence is not.
And the parots?
Contralateral parotid mean under 26 gray if possible to save some salivary function. The ipsilateral one will be higher given his bulky level 2 disease. We do our best.
Which brings us to the final reality check for case A.
Checkpoint 4. Hypopharynx default number 4. Prognosis is brutal.
The stats are not kind, are they?
They were terrible. 5-year overall survival for hypopharynx is around 30%. That is one of the worst numbers in our field.
And what about failure patterns?
Most patients who fail locoregionally. And 25% develop distant metastases in the first 2 years. That is the highest rate in head and neck cancer.
So what does that mean for your planning mindset?
It means locoregional miss is unforgivable. We have one shot.
When you are uncertain about a margin.
I hear on coverage.
Every time.
When you were debating a nodal level.
I include it.
When the optimizer wants to pull dose off a structure that might have disease.
I override it. I can manage dysphagia. I can manage xerostomia. I cannot salvage a geographic miss in the hypopharynx. Before we sign off on case A, let's run the QA checklist. Imagine you are presenting this plan to your attending.
Okay. RPLN included. Yes, bilateral. C1 to cranial hyoid. Bilateral neck. Yes, levels 2 through 4 bilateral plus escalations. Inferior extent generous. Yes, 1.5 centimeters beyond visible disease. Cervical esophagus included. Level 6 included for the post-cricoid trigger. Yes, level 5 for N2B. Yes, bilateral. OARS optimized without compromising coverage. Yes.
Case A is signed, sealed, and delivered. Now, take a breath. We are going to shift gears entirely. Case B.
This is a different beast. Post-operative radiation.
Case B profile. We have a 61-year-old man. He is status post-total laryngopharyngectomy with a free jejunal flap reconstruction.
So the normal anatomy is gone.
Gone. He had a T4A N1 post-cricoid squamous cell carcinoma.
Post-op cases are visually confusing. The anatomy you know is gone. What is the critical history here? What do I need to know?
Preoperative tracheostomy was placed 3 weeks prior to surgery due to airway compromise from the tumor.
Okay, stop right there. That is a crucial detail. Do not lose track of that pre-op track. It changes everything.
The pathology report is back. Positive posterior margin tumor at Inc. Subglottic extension to 8 millimeters below the true vocal cords. Extranodal extension, or ENE, in a 2.4 centimeter level 3 node. And a close tracheal margin, just 2 millimeters.
Wow. And level 6?
Level 6 nodes were not dissected.
Not dissected. Okay. And the surgery was 4 weeks ago.
Wound is healing well. The jejunal flap is viable, tolerating a soft diet. No recurrence on imaging. He is here for adjuvant therapy. The consult question. How do I contour this post-laryngopharyngectomy bed, and what are my dose targets?
This is not definitive planning. The rules change in the post-operative setting. There are 4 main differences you need to be aware of.
Okay, what's difference number 1?
No GTV. The tumor has been resected. There's no gross lump to circle. I'm defining a tumor bed based on preoperative imaging, the operative report, and surgical clips.
Difference number 2.
Wider margins. In definitive planning, I use 5 to 10 millimeters from the GTV. In post-operative planning, I use 1 to 1.5 centimeters from the preoperative tumor extent.
Why the jump in margin size? That's a big difference.
It is. It's because of the uncertainty inherent in defining a tumor bed after resection. Tissue planes are disrupted, landmarks are altered, and that flap reconstruction changes the anatomy entirely. The surgeon has moved things around. We have to paint with a broader brush.
Okay, difference number 3.
Pathology-driven boosts. Positive margins in ENE define my high-dose volumes. We aren't boosting what we see, We are boosting what the pathologist saw.
And difference number 4.
Timing. We need to start by 6 weeks to avoid worse outcomes. Every week of delay allows remaining clonogens to repopulate.
Let's define the tumor bed. How do you physically do this at the workstation?
At the workstation, I have the post-op CT sim, but I also have the preoperative CT and MRI fused to it. The larynx is gone. The hypopharynx is reconstructed with that jejunal flap. It looks like a sausage link in the neck.
So what's step 1?
Step 1. Identify the surgical clips. These are my breadcrumbs. Surgeons often place clips at the site of close margins. Step 2. Correlate with preoperative imaging. I look at where that post-cricoid mass sat on the pre-op scan and map that location onto the post-op anatomy. Step 3. Define the CTV tumor bed.
So you take the pre-op JTV location and add that 1 to 1.5 centimeter margin.
Exactly. The operative report said the posterior margin was positive. That means I need to paint that area for a high-dose boost, 63 to 66 gray. I am contouring the neopharynx, the reconstructed swallowing tube.
Do you treat the whole flap?
The jejunal flap itself isn't high-risk. Cancer doesn't usually jump into the donor tissue immediately, but the interface between the flap and the native tissue is. I am being generous at those anastomotic junctions.
And the posterior boundary.
The prevertebral fascia. His positive posterior margin means the tumor was right up against the spine. I need to respect this plane carefully. I'm including the prevertebral fascia in my high-risk volume.
No for the nodal volumes.
Preoperative nodal GTV plus a 1 centimeter margin. His level 3 node was 2.4 centimeters with ENE. I am extending from where the node used to be. Note, I am not just filling the empty space left after dissection.
What do you mean?
If there was muscle invasion described in the path report, I'd take the whole muscle bed. Here, standard expansion applies, but I cover the full level where the disease was found.
And level 6?
It wasn't dissected, but this is a post-cricoid primary with subglottic extension. Level 6 coverage is mandatory. Since it wasn't dissected, I'm treating it as an elective volume, 50 to 54 gray.
Let's talk about boost volume painting. We have a lot of different risk levels here.
3 tiers again. High risk, 63 to 66 gray. This goes to the areas of proven microscopic residual disease, the positive posterior margin, the tumor bed where the ENE node was, and the closed tracheal margin.
Intermediate risk.
57.6 to 60 gray. This goes to the general tumor bed with that 1 to 1.5 centimeter expansion and the dissected neck levels.
Wait, why 57.6 to 60 gray for the dissected neck? Standard adjuvant dose is usually lower.
Yeah, this is a point of some debate, but it comes from Cobalt-era data suggesting that hypoxic post-surgical beds need a higher dose than virgin elective tissue.
Because of scarring and poor blood flow?
Exactly. The scarring and surgical changes reduce oxygenation, making any residual cells more radioresistant. It is debated, but I err on the side of adequate dose, usually 60 gray, rather than treating it like an untouched elective volume.
And low risk?
50 to 54 grays for elective nodes that were not dissected, including that undissected level 6.
Now we arrive at a crucial segment for this case. This is arguably the most common failure point in post-op plans, stoma coverage.
This is where post-operative hypopharynx planning really diverges from other sites. This patient has 3 distinct stomal recurrence risk factors.
Walk us through them. Risk factor 1.
Preoperative tracheostomy. He had a tract placed 3 weeks before surgery. This is classic. Tumor cells can seed the tracheostomy tract as the tube is inserted or while it sits there irritating the tissue.
Okay. Risk factor 2?
Subglottic extension greater than 5 millimeters. His path showed 8 millimeters. Subglottic tumors have paratracheal drainage that puts the stoma at risk.
And risk factor 3?
Closed tracheal margin, 2 millimeters. That means the cancer was nearly at the cut edge of the trachea that is now sewn to the skin.
He has the trifecta.
Any one of these would trigger stoma coverage. He has all 3. So I am contouring the stoma site as a structure. My target is 60 gray to the surface.
How do you achieve 60 gray to the skin surface? Usually we spare the skin.
In the IMRT era, I don't necessarily need a physical donut bolus, which can be uncomfortable. I contour the stoma and a layer of skin around it. I tell the optimizer to push dose to the surface, and I use surface dosimeters, OSLDs or TLDs, at the first treatment to confirm we are actually hitting 60 grays.
So you're not just treating the hole?
No, absolutely not. The goal is treating the paratracheal soft tissue and lymphatics where recurrence actually seeds.
Finally, concurrent therapy. Do we add chemo?
Surgery was 4 weeks ago. We plan to start next week, hitting that 5-week mark. He has positive margins and ENE, the Cooper and Bernier data The EORTC and RTOG trials, the benefit of adding cisplatin is seen specifically in patients with positive margins and/or ENE.
So we're planning cisplatin?
Like weekly cisplatin, 40 milligrams per meter squared, given his post-op status and recovery. It is more tolerable than the high-dose bolus.
Let's run the case BQA checklist.
Okay, wider margins, yes, 1 to 1.5 centimeters. Level 6 included, yes, mandatory for post-cricoid. Stoma covered, yes, 3 risk factors present, targeting 60 gray to surface. High-risk bed boosted, yes, 63 to 66 gray, ENE level boosted. Yes, concurrent chemo, yes, timing, starting of hit me.
Question 1. What are the standard borders for RPLN, or level 7A, coverage in hypopharynx cancer?
The answer is superior border at C1, inferior border at the cranial edge of the hyoid. The rationale is that the hypopharynx drains to retropharyngeal nodes regardless of visible disease location. Unlike the larynx, we always cover this.
Question 2. What specific clinical or pathologic features trigger the inclusion of the stoma in the radiation field?
The answer is preoperative tracheostomy, subglottic extension greater than 5 millimeters, and a close or positive tracheal margin. The rationale is that these factors increase the risk of stomal recurrence via paratracheal seeding or lymphatic drainage.
Question 3. Why is the inferior CTV margin in definitive hypopharynx planning larger than in other subsites?
The answer is surgical series demonstrate 2 to 3 centimeters of submucosal spread not visible on CT or MRI. The rationale is to prevent marginal failure. We require a 1.5 centimeter margin beyond visible disease, often extending to the cervical esophagus.
Question 4. In a patient with N2B, disease bulky level 2, which elective nodal levels must be added?
The answer is level V, the posterior triangle, and potentially level 7B, the retrostyloid. The rationale is that bulky upper neck disease significantly increases the risk of posterior triangle and high retrostyloid involvement.
Excellent. Now, let's distill this into our clinical pearls, the 3 pitfalls that lose patients.
Pitfall 1, inadequate inferior extent.
The cause?
Trusting the image or scope too much.
The fix?
Always add a generous craniocaudal margin, 1.5 centimeters plus. If the apex or postcricoid is involved, go to the superior mediastinum, narrate your cursor. I'm adding 1.5 centimeters below the lowest visible disease.
Pitfall 2.
Missing the RPLN,
The cause?
creating hypopharynx like glottic larynx.
The 6.
Default is on NC1 to cranial hyoid. Every time.
And the last one?
Pitfall 3. Underdosing the high-risk post-op bed.
A cause?
Using tight definitive margins or missing stoma triggers.
And the fix?
Use 1 to 1.5 centimeter margins. Check the 3 stoma triggers. Track, subglottic, tracheal margin.
So to sum it up,
Hypopharynx planning is unforgiving. These defaults exist because this disease spreads where you can't see it, drains where you don't expect it, and kills more patients than any other head and neck subsite. When in doubt, cover more. Optimize OARs after targets are right, never before.
say the defaults with me one last time.
1. RPLN-ON. 2. Bilateral neck on N. 3. Inferior extent. Assume it goes lower than you want. 4. Prognosis is brutal. Local regional miss is unforgivable.
That is your checklist. Run it every time. Today, we built muscle memory with 2 complete cases. Next time, in episode 33, we shift from planning to decision-making.
Right. Who gets definitive chemoradiation versus surgery? How do we assess response? And when do we involve palliative care early?
It's the big picture.
That is the integration episode. See you there.
Complete practice oral boards at radonsmartlearn.com and subscribe to Rad Onc Smart Review for our next episode. Thanks for tuning in.